So Jeff, what do you do with the patient population right now before we have approval of the combination of the immunotherapies? Rapidly progressive patient, rapid pace of disease, bad performance status maybe, no biomarkers for therapy. What do you give them? So they're NRAS negative, they're c-KIT negative, they're BRAF negative. So what do you give them?
Yeah, that's the hardest question. I, believe it or not, I do give them ipilimumab. I'm not a strong believer in chemotherapy, but it's certainly an alternative is to try to bridge them, as we say, and give them some chemotherapy, hopefully getting a short-term response, which you can have, and then when they're in response, treat them with the ipilimumab.
So no one on the panel here would give biochemotherapy?
I wouldn't say that.
And
I bet Omid would perhaps feel the same way.
I would give, the idea of biochemotherapy has got to go back to tumor kinetics. Rapidly dividing tumor cells are the ones that respond to chemotherapy, regardless of what the tumor type is. And there are patients out there, and we have them, who are rapidly dividing, growing, even those who have failed combinatorial blockade, that we have given biochemotherapy to. And they have done well. And they have done, once you get rid of that high growth fraction, it's not 100%, nothing is. But you can get those patients to immunotherapy and look for a benefit. I would not give that patient ipilimumab.
But to be fair, you cited a patient with a poor performance status, presumably high LDH, large disease burden. To be honest, nothing is going to change the outcome in our current armamentarium if that's a BRAF wild-type patient. But that being said, if a patient has a large disease burden with a high LDH and can tolerate biochemotherapy, especially if they're a younger person, yes, then that would be one of the scenarios, not a common one, but one of the scenarios where I would use biochemotherapy to try to debulk them and then hopefully put myself in a position where I could stop, consider using IPI.
And give immunotherapy.
That paradigm is shifting with the combination checkpoint blockade that Dr. Snoll and Dr. Wolchuk presented. If you look at the response, majority of those patients had greater than 80% response within a couple of weeks. And hopefully we can, and we will, understand from all of the randomized trials who and how.
Yeah, it was good data. It wasn't within a couple of weeks. The responses did occur within 12 weeks. And there were patients who had high growth fractions, high bulk disease that had very rapid responses. But there are also patients that don't respond. And for those, we still don't have good therapies. If they do have a BRAF mutation, we can offer them the combination. If they don't have a BRAF mutation, we're in the same boat, which is not a lot to offer other than biochemotherapy or some type of regimen.
We just had ASCO. And I'm at least hopeful of an experience we had that I presented, and that's the use of combination targeted agents in NRAS melanoma. So we've seen, and it's very preliminary, but we've seen some rapid responses, very reminiscent of the BRAF responses, with the combination of a MEK inhibitor and a CDK4/6 inhibitor. So it's preliminary, and it's optimistic in terms of what we've seen, but we're hopeful that as we treat more patients, that we'll see this hold up, and even in more patients.
This is NRAS mutant, or also in wild type?
This is NRAS mutant. We have not looked at wild type yet.
Wild type for both NRAS and BRAF.
Right.
So then what is the role, Jeff, and well, any of you can take this question. Is there a role for combining targeted therapy, so BRAF inhibitors, dabrafenib, trametinib, or dabrafenib alone, or bemurafenib alone with immune therapies?
I think there's a great role for it. The problem is the first time that was tried, it was a stunning failure because of toxicity, as you may remember. I think Tony Rebus published in the New England Journal the initial experience with Vemu plus ipilimumab, with 4 out of 6 of the first patients in the first cohort, and then 4 out of 6 patients in the next cohort with lower doses of Vemu having dose-limiting hepatotoxicity. So I think that gave everyone pause. I think the possibilities would be for BRAF-MEK, and I would always combine a MEK inhibitor with the BRAF inhibitor if I could, with the possibility of adding a PD-1 or a PD-L1 antibody. That would be a nice trial. I believe such a trial is being planned and will start soon. That I like.
It's not clear, by the way, that dabrafenib and vemurafenib might have the same liver toxicity. I don't think
Right.
we know that at the moment.
Absolutely
Is that right?
correct.
Actually, there's going to be, been a presentation that trial that involved MD Anderson and Memorial and ourselves that looked at dabrafenib and dabrafenib plus trametinib in combination with ipilimumab. And actually, it looked as though the dabrafenib plus ipilimumab was tolerable, as expected with both single agents. On the other hand, when they combined the DAB and MEK inhibitor with the ipilimumab, there was much more toxicity. It's very small numbers of patients, but it does appear that at least you can combine dabrafenib with, or a BRAF inhibitor with ipilimumab. And whether the outcome is better is we don't have that data.
So in these patients then, if we have concern about in the combination combining the targeted therapy and the checkpoint inhibitors together, what about sequencing them? How do you then, if you start with the targeted therapy initially, how do you sequence them? Then when do you continue with that if they have a response? Do you switch over to an immunotherapy with that? How do you sequence these?
If it's a patient with really fast-growing bulk disease, it's going to be tough to initiate BRAF or BRAF-MEK and then stop. That's going to be difficult. But in someone without a huge disease burden, a well-chosen patient, I think you could do a month or 6 weeks worth of the BRAF drug and then immediately come in with immunotherapy. That would be doable.
Although all of this has to be vetted through clinical trials, I just want to make the point that even though vemurafenib and ipilimumab had significant toxicity, even though the data with dabrafenib, trametinib, and ipilimumab showed colitis and colon perforation, that there is data out there, vemurafenib and an anti-PD-L1, which was tolerated and is still ongoing. There is dabrafenib, trametinib, and an anti-PD-1 trial that is accruing at this point. So we continually have to come back to this question because combination is the answer